Checking for drug-drug interactions, or DDIs, when treating outpatients with COVID is important because they're often taking several other medications. There are a lot of resources to check DDIs. Some are built into your electronic chart or prescribing system, and some are outside of your internal system. The University of Liverpool's DDI checker is specific to COVID and has very good information. You can search COVID drugs in the first column and co-medications in the second column. You can also check by class. It gives you information about the interaction itself and potential alternatives to the co-medication in some cases. You can select Table View to see all interactions. The co-medications you searched will be in the left column. The COVID drug and results to the right. The red circle indicates that the medications shouldn't be administered together. The orange square means that there's a potentially significant interaction that may require additional monitoring or dose changes. The yellow triangle indicates a potential weak interaction. So it's important to note in case something happens, but no additional monitoring or dose changes are generally needed. And the green diamond means that no significant interaction is expected. If we look at nirmatrelvir-ritonavir as the COVID drug with the co-medications amiodarone and atorvastatin, it tells you not to co-administer amiodarone with nirmatrelvir-ritonavir and warns of a potential interaction with atorvastatin. It's important to click on Do Not Co-Administer and Potential Interaction to get the whole story and recommended action. So if we click on Do Not Co-Administer, here's the guidance. You can see the issue is amiodarone concentrations may be increased. Plus, amiodarone has a long elimination half-life, so temporarily stopping it may not help. So you really don't want to co-administer these medications, and using an alternative COVID treatment is your best bet. Now, your internal system may or may not have an alert to warn you about prescribing these together. Sometimes the interaction checker in your electronic prescribing system has different severity and recommended actions compared to one at a pharmacy or a third-party website. Pharmacies usually opt for higher severity and stricter rules on dispensing, so be aware of this, especially since we have such a short time to get the medication to the patient. You don't want piles of messages from the pharmacy that you have to review and make decisions on. You want to have an action plan in place for common interactions, whether it be to prescribe an alternative antiviral, pause a co-medication, or lower the dose of a co-medication. That brings me to atorvastatin. Remember it said there was a potential interaction? Let's click on this to see the guidance. Atorvastatin concentrations are expected to increase, so atorvastatin should be temporarily stopped during treatment, then restarted 3 days after the last dose of nirmatrelvir-ritonavir. The risk here is rhabdomyolysis, which is the breakdown of muscle cells, because of increased exposure. This is a problem for all of your patients, but especially older adults. So again, please have a plan in place. Write your prescription for nirmatrelvir-ritonavir, but also write to pause atorvastatin and resume 3 days after stopping nirmatrelvir-ritonavir. Why 3 days? We'll cover that in a later lesson. Could you change the statin? Sure, but by the time you get through insurance and sort everything out, you've missed the short window you have to get the antiviral to your patient, or they've missed getting appropriate counseling and are now at a higher risk for adverse events from taking nirmatrelvir-ritonavir with atorvastatin. The most important thing here is consistency. Get familiar with an interaction checker, use it consistently, or teach your staff to use it consistently so you know its little quirks and have action plans in place for common interaction. The University of Liverpool's checker is considered the gold standard by many clinicians. It's specific to COVID-19, updated regularly, user-friendly, and provides clear management strategies with references. But you may come across situations where you need to use some other DDI checker, like if a certain drug isn't listed in the Liverpool checker, or if you want to check interactions between the other medications the patient is taking. The Liverpool website only checks the COVID medication against the co-medications you input. There are many other DDI checkers available. Hippocrates or drugs.com can be downloaded as an app on your phone for free. Or if you have a subscription to LexiDrug, Micromedics, or the Dynamed interaction tool, those can work well for you too. You can find a list of these with links in your handbook. One final note about the Liverpool checker and other DDI checkers. You may be wondering why the quality of evidence says very low, which was the case for amiodarone and atorvastatin. Many databases use information that predictably ranks lower than data from large randomized clinical trials. One of the reasons for this is process-related. Prior to the approval or emergency use authorization, many drugs aren't tested against all possible combinations to determine their DDIs. This would be complex and impractical. Often, the checker uses index medications, which are drugs with well-known effects on metabolism, to predict potential interactions. So DDI checkers are a valuable tool, but they should be used together with clinical judgment, other resources, and careful patient monitoring.